أول slide. Hyperprolactinemia. Hyperprolactinemia characterized by galacturia, which means lactation in absence of breastfeeding. I mean nursing woman, and in male, it should be associated with gynecomastia because there is no galacturia in male without gynecomastia. And mostly in male, there will be hypogonadism. Okay? Unless, I'm sorry, gynecomastia in hypogonadism. The etiology of hyperprolactinemia, it is a bit complicated. The etiology is a table which many causes. So it is very important to know that it is not classified like that, one, two, three, four. It is classified to classes. The classes of etiology. First class, physiological causes due to stress. Pregnancy, of course, pregnancy is also physiology, and lactation. This is logic. During lactation, there is hyperprolactinemia. Nipple stimulation. Okay, nipple stimulation by the child. Okay, and coitus during sex relation, and even during child crying. When a lady who labored recently, when the child cry, there will be a state of hyperprolactinemia. The second class of causes will be drugs, and many drugs can cause hyperprolactinemia. The most important will be psychiatric in form of antidepressants, antiemetics. One of the important antiemetic will be the metoclopramide, or dopamine depleting agents like methyl dopa. Its famous name is Aldomet. This is an old drug, antihypertensive, nowadays used only in pregnancy because it is safe. And estrogen, which is present in oral contraceptive pills. So this was the second class. The third class, pathological. In pituitary, either microadenoma or macroadenoma. So in acromegaly, it was macroadenoma. In Cushing disease, micro. Here, in hyperprolactinemia, either micro or macro. In primary hypothyroidism for unknown causes. PCOS. What is PCOS? Polycystic ovary syndrome. And uncommonly in chronic renal failure, and in acromegaly, associated with acromegaly, and rarely in chest wall injury, herpes zoster when it involves the chest, and ectopic, secreted from another place, the prolactin from another place. I will release my hand to test whether you are hearing me or not. Yeah, my dear, the second slide is diagnosis. So after knowing the definition of hyperprolactinemia, the classes of cause, please concentrate, not only one, two, three, four. We have classes of groups of etiological causes. Here it is mentioned diagnosis. The most important diagnostic method will be prolactin level. So you must know the reference level for that laboratory. The higher the level, the more pathological, which means here also we must know that sometimes it is physiological, we mentioned. So it is very important. If it is thousands, so this is pathological, while if the reference is say 40 and the increase is to 50, this is not so significant. It should be repeated, while if it is high, this is mostly pathological. The treatment is easily the treatment of the cause. If it is secondary, And for adenomas or hyperprolactinemia as a general, the best drug will be the dopamine agonist, which is the most famous bromocriptine. Bromocriptine is a very famous drug in neurology and in endocrinology. Parlodil, its trade name. For you, it is very important to know the chemical name or the pharmacological name, the bromocriptine and related ergots. If it is large, and especially macroadenoma, surgery will be very fit because you want to save the vision. We mentioned that it will compress or press on the chiasma, so there will be visual defects. You must save the sight of the patient, so surgery. Or if it is not operable, radiotherapy. Now, the third slide will be acromegaly. Acromegaly, many times I told you in the introduction for endocrinology, from its name, acro, fingers. Acromegaly, enlargement of fingers. This, by definition, acromegaly it appears in adulthood, while if it starts in infancy, it is called gigantism. Gigantism only increase in the height, which means that before 18 years, the epiphyseal end plates are not closed, so the person or the patient will be high, tall, the increase in height. While in adulthood it's closed, so there will be enlargement of the not the high will increase, while enlargement of other organs. We mentioned that the features. First. In 25% there will be impaired glucose tolerance, pre-diabetic, while genuine diabetes in 10%. These patients, they are prone for colonic cancers. And this is an introduction for them. The diagnosis will be varied by estimation of the growth hormone level. And after oral glucose tolerance test, okay? While in diabetic patients, the insulin glucose, glucose factor will be low. We here didn't mention the clinical feature because the previous lecture in the pituitary gland, I mentioned that enlargement of the head leading to unfit heart, the ring will be not fit. The shoe, the patient will change his shoe frequently. Prognathism and enlargement of the feet. So we mentioned this. Here only outline of the management here because it is macroadenoma. Surgery will be through the transsphenoidal method. The neurosurgeon will be able to remove the adenoma. If this cannot be done or performed, medical treatment is by somatostatin. You remember I told you soma is the body. Statin, it will seize the enlargement of the body. Or by dopamine agonist. I told you the bromocriptine, parlodil, is also fits here. Okay? The third topic to complete the pituitary will be the craniopharyngioma. Craniopharyngioma, this also mentioned in the previous lectures, first part of pituitary. It is different from the acromegaly. It is a benign tumor, while in acromegaly, if it is due to macroadenoma, it should be dealt with. The origin of the craniopharyngioma is from the Risch's pouch. What is the Risch's pouch? During the embryological development of pituitary. There is a remnant pouch. In adulthood, it's called Risk's pouch. So this tumor arises from Risk's pouch. Its location, it is supracellular extension. Okay, it got supracellular extension, so it definitely affects the vision. Okay, and the hypothalamus. When it is when the pathology reaches to the hypothalamus, there will be hyperphagia, increase in the appetite, because in the thalamus there is the satiety is controlled there. So there will be hyperphagia, eating a lot. So this will lead to obesity and thirst. Also the center to control the our desire to drink water. And there will be disturbance in the temperature, because also the center of the regulation for the thermostat is there. So temperature regulation will be disturbed. So the diagnosis, although this is a very rare condition, the diagnosis will not be difficult in a patient or in children obese. The child eats a lot. There is disturbance in the temperature regulation, and the diagnosis will be very easy if you know that in X-ray of the skull. Probably nowadays X-ray of the skull is no more used because we have CT, we have MRI. But craniopharyngioma, characteristically on skull X-ray, it shows calcification. The treatment is surgery because, as I told you, it got extension. If cystic, the surgeon will drain it by a very minute tube to drain. If not, the treatment will be radiotherapy. Okay? Now, this is the last topic to complete the pituitary gland, diabetes insipidus. Also, this very rare disease. Probably in my life, I saw one or two cases. Once I told you the patient will urinate more than, say, 30 liters of urine. So very rare condition, but you'll be able to diagnose it if the patient tell you that every minute I go to toilet to urinate. So this large amount of urine will cause thirst, of course, unlimited thirst. The patient wants to drink to compensate for this loss of large amount of water and electrolyte in urine. So in causes of diabetes insipidus, in the previous lecture I told you either cranial or peripheral. In cranial, which is called also central, cranial structural lesion, or the cause will be genetic. DID mode. In the introduction of endocrinology, I told you DID mode, the DI, the diabetes insipidus, the DM, diabetes mellitus. Okay, the O, optic atrophy, and the D will be deafness. I saw only one case. Okay, or nephrogenic. Nephrogenic is called peripheral due to genetic factors. The V2 receptor mutation. This V2 receptor is present in the renal tubule, okay, or cystinosis. From its name, deposition of the cystine in the renal tubule, or metabolic causes due to hypokalemia, chronic hypokalemia, or hypercalcemia. Concentrate here for the MCQ, hypokalemia and hypercalcemia. Some drugs can cause diabetes insipidus. One of the old psychiatric drugs, it is called lithium, a lot of side effects, or dimercycline. This is one of the drugs related to tetracycline, or poisoning by heavy metals like lead or arsenic, or chronic kidney conditions in ADPKD, autosomal dominant polycystic kidney disease, or in sickle cell anemia. Okay? So the diagnosis, after mentioning the sets of the etiological factors, okay, here also in diabetes insipidus, like hyperprolactinemia, you cannot calculate 1, 2, 3, 4. We have sets of causes. In drugs, a lot of drugs. In genetic, many causes, or in acquired, many causes, peripheral or central. In central, also many causes. So, where you are asked about the causes, don't mention 1, 2, 3, 4. You must mention, start by classes of causes. Diagnosis, the most famous diagnostic method will be water deprivation test. From its name, you will deprive the patient from water. Tell the patient, don't drink water. Of course, here to establish the diagnosis, you must exclude psychogenic causes of polyuria. We have psychogenic polydipsia. In many psychological disorders or psychiatric, the patient will drink a lot of water, part of his anxiety or part of the psychiatric disorder. The patient drink water and go to toilet. Drink water and this is not diabetes insipidus. This is called psychogenic polydipsia. When we come to the diagnostic method to differentiate cranial from nephrogenic causes of diabetes, you must instruct the patient there should be no coffee, no smoking, no tea, okay, no extra fluid. You remember, like insulin, glucose tolerance test. We have instruction to our patient. Here also we have instructions for the patient. We'll tell the patient no coffee, no smoking, no tea, no extra fluid. During the test, it is very important to check the body weight. If there is loss of the body weight more than 3%, we must stop the test because the patient will be in danger. Okay, we will calculate or measure, not calculate, measure the urine volume. Then we will send the urine and plasma for the laboratory to check the osmolarity. If the plasma more than 300 milliosmol, so and the urine is less than 300 milliosmol, this is definitely a sort of say diabetes insipidus. The treatment, very easy here to mention. If it is peripheral, I mean secondary to many causes in the peripheral type of diabetes, we will treat the cause. While if it is central, we will prescribe DDAVP. This is desmopressin. We have the antidiuretic hormone in form of, nowadays we have spray nasally or injections. So this is very important to be known by you. Recently, we have vasopressin or desmopressin nasally used, and we have injections. I think we completed, okay?